to welcome all of you to this session. This session is titled Building Protective Breastfeeding Environment Using the Nourished Truth Toolkit. So this session is made possible by our long-term partner, Lacta Hub, under the Family Larson Rosenquist Foundation, that is a partner of Amref International University. And before I talk about how the session looks like, breastfeeding is an intervention in primary health care that we know research has demonstrated there is no formula that has been produced that ever matches breastfeeding. And I don't think there will be. And this is why, for us, we have to protect breastfeeding. We know that there are changing dynamics, populations are changing. Yesterday in the plenary session, I had a privilege to speak, and I talked about how do we strengthen primary health care as universities. Universities are at the supply side of future and current primary health care workers. So if universities can prioritize primary health care interventions like breastfeeding, then we will be able to have healthy populations and sustainable primary health care. And this is why, for us, we are very grateful that we have actually an organization. When everybody else thinks, oh, why are you talking about breastfeeding? It's such a normal thing. You'd be surprised that with the changing dynamics, it is not as normal as people think. It is also assumed that every mother knows how to do this. But the competitors against breastfeeding are working so hard while we are letting this important free intervention, we are letting it go because somebody else is working very hard against it. And this is why this session is dedicated to looking at this. So in the room, we have a number of people who are going to help us do this. My name is Professor Alice Lakati. I'm an associate professor of public health and epidemiology, passionate about breastfeeding, and I've done a lot of research in this area, but I'm really going to be guided. This session is going to be supported by a team of experts. So we have Dr. Chantel. Dr. Chantel is a health systems director. She will say something about her organization. She's based in South Africa. I don't want to spend time reading her bio. It is in the website. Please interact with it. She will lead this part where she will talk about the Nourished Truth, the work they've done in South Africa, and maybe they'll also mention in Ghana. She will be assisted by Angelica. I don't want to pronounce the second name before I get it wrong. So Angelica is a co-author of Nourished Truth Handbook, which is it's called Nourished Truth Policy and Research. She's a Nourished Truth Policy and Research Manager. She will also tell us more about herself. Then from there, we shall now go into a panel session. So in the panel session, we are honored to have a number of colleagues from Kenya being part of this. So we'll have Veronica Kirogo. Veronica, she is the Director of Nutrition and Dietetic Services at the State Department of Public Health and Professional Standards, Ministry of Health. So we really have the highest person from the Ministry of Health. Thank you so much, Veronica, for joining us. We are also glad to have Esther Mugusu. Esther, I know Esther from different angles. Very happy to have Esther here. She's the Director of Nutrition and Wellness and School Feeding Program in Nairobi County. Something about Esther, she's very passionate about school feeding programs. And Nairobi County has got a program called HEALA County. HEALA County, Dishi is a slang to say food. She will say something about it when her time comes. Then we'll have Dr. Jane Mate Rodriguez, who is a consultant pediatrician from, I think she's from Mpisha Hospital. Yes, thank you so much. We have been talking online. It's good to see you in person. I think you look different from the picture. Because all along I was looking for you. We also have Millie Karina, a nurse midwife. Millie, Millie, you also look different. Wow. These are people we have been working with online for now years, but we thank God that we get an opportunity to interact. So without wasting a lot of time, this is how the panel, this session is going to run. So we will have the first session led by Angelica and Chantel. Then after that, we'll come to the panel. Welcome.
My name is Angelica Grimberg. It's an Afrikaans surname, so it is quite tricky. I come from South Africa and I work for an organization called the Healthy Living Alliance. We are a civil society advocacy group that are fighting for food justice, basically trying to make sure that everyone in South Africa can access nutritious food through better food environment policies. But today we are going to be talking about this operational handbook, and we want to launch it to you and this Nourished Truth project that Dr. Chantel Witten and myself and lots of different colleagues from South Africa have been involved in. Just on behalf of myself and Dr. Witten, we would just like to declare that we have no conflicts of interest. It is very important, especially when talking about child health, that neither of us have ever received any sponsorship or funding from the infant formula industry. And of course, we just want to acknowledge all of our colleagues in South Africa that have been part of this project. We are representing a very big group of people, as well as then, of course, the Family Loss and Rosenquist Foundation for being a very strategic partner in this whole process and also funding the project. But I think it's really important, although we're here today to really go through the Nourished Truth project, I think it's really an important journey to take you down why there is this issue in South Africa, and I'm sure in other countries we'll probably see very many parallels. And just really looking at this whole journey from the 1990s all the way to up until now, where we're at, and why there has been this need for breastfeeding advocacy, why there is this desire for infant formula in the country, and also then looking into those commercial determinants of why the CMF industry or the formula industry actually has so much power as well. So if we go back to 1990s into the early 2000s, there was a huge issue with HIV in our country. And during that time, there was our National Department of Health was actually giving out free formula as protocol for HIV positive mothers. Then, of course, there was a lot of advocacy going on around that. And I think it's similar to many African countries where there was a shift. We realized that breastfeeding can happen with correct ARV treatment. And in about 2011, 2012, there was the Tshwane Declaration was signed, and when our Department of Health, as the PMTCT program was rolled out, they stopped giving free formula. During 2012, it was a very important year because South Africa adopted our own regulation based on the International Code of Breast Milk Substitute Marketing called the R991. And it obviously then restricted a lot of marketing of CMF products and infant formula products and baby foods as well. So from 2012 all the way up until about 2021, there was a lot of ongoing work. Of course, a lot of publications from academics talking about conflicts of interest. There was the Second World Breastfeeding Conference in South Africa. So a lot of work carrying on around this. But during 2021, there were two big sort of events that happened. There was, I think Dr. Witten will probably be able to give more details about this lady, Prof. Sabande, that she was put onto the Nestle board, and there was a huge outcry from academics about this as a big conflict of interest. But then also on top of it, we had the Not Today Nestle campaign that happened. And I'm going to pause on this because I'm going to go into the Not Today Nestle campaign a little bit more in detail so that you can see an example from South Africa of how the industry actually does work and what kind of marketing they use. Then In 2002, we started this Nourished Truth project. So under the University of Western Cape and under Dr. Vitten's guidance, the project was started, this Nourished Truth project that we will get into now. As well as the World Health Organization and UNICEF also created, published that report talking about that $55 billion industry that is marketing products and how it works. And South Africa was one of the countries that was involved in that report. So then throughout the years, UWC did phase 1 of the Nourished Truth project, and then HEALA took over and we completed this Nourished Truth preparation project in 2025. And now, of course, we're here in 2026 launching the operational handbook. And I do want to note that this operational handbook is the planning phase of creating a countrywide campaign of how we think it could happen in our country. We have not actually implemented it yet. As you see, it was only completed last year, and now we are here with our handbook. But it is really trying to look back on all of the experiences from phase 1, phase 2 that you'll hear about now, and then really trying to see what we can do and how, if it can work in other contexts, and creating a blueprint that could be followed. Next slide. So I do just want to take a little bit of time with this Not Today Nestle campaign, because it really does show 3 things. Sort of how the industry actually does market their products, that we as civil society, as academia, we actually can combat it, and also that it introduces this idea of commercial determinants of health and the commercial interests that lie with these big companies. So basically, in a nutshell, what happened with this Not Today Nestle campaign, it was a 3-day campaign. On the Tuesday, or 3 or 4 days. So on the Tuesday, on the 21st of August in 2021, this advert came out, the Stockville Mom and Child Forum, in online platforms. Of course, this was now, because I mentioned we've got our R991 regulation that's been around since 2012. A lot of academics working in both infant and young child feeding, as well as a bit broader in the ultra-processed food environment, public health sector, they noticed this advert and saw that it was firstly a violation of our R991. They had numerous violations that you can find the details in this article. They were also ethically just marketing very horribly. So firstly, they used the word stockfill, and a stockfill is a community-based savings scheme that is really a lot of lower income households rely on in South Africa. They had a nurse with a PhD on their panel along with their reps, so making it seem that the products that they were going to be marketing was actually going to be healthy or endorsed by health professionals. And then on top of it, the products that they endorse that are actually ultra-processed in nature, and it's all for above 6-month-olds. So things like Cerelac, the Nido milks, not necessary for children to actually be consuming. And then another added one was that they actually incentivized caregivers to join the stockfill because they were offering a 500 Rand voucher for a grocery store that we have. So of course, numerous violations, ethically, illegally, everything. So it created a huge uproar. What was really important was that this happened on the Tuesday. The academics wrote a letter. By Wednesday, it had been circulated globally, had been signed by many people. And then HEALA, the organization I work for, the civil society advocacy group, was able to mobilize resources based and create communication materials. So a few interviews went out, and a very reputable media house then took on this and wrote a whole article about it. On the Thursday, Nestle replied to Daily Maverick, and they said that okay, sorry, we'll cancel this event. And I think it's a really, really, really important event that happened. The stockfill, this Not Today Nestle campaign has actually been spoken about a lot of how this can happen so quickly. We are now trying to plan year-long kind of advocacy plans, but things like this do happen all the time, and we have to be wary of it. So just in the next slide. So then just looking at this, and it's also especially that there's so many students in the room and we are at a conference, and this model, this commercial determinants of health model has recently come out. So it's really framing this issue quite well of how commercial determinants are really important to note. So what we did with this Not Today Nestle campaign is that we looked at the different levels, and basically one of the practices that is used, so in that circle over there, is marketing practices by the CMF industry, by food and beverage industries, by tobacco, alcohol. They all use the same kind of playbook. So with this, we looked at the marketing practices, and at levels 1 and 2, we could see these are the like political, economic, regulatory type of systems. And we could see that firstly, Nestle had violated our regulation unlawfully. And also on top of it, during the time that they said that they'll cancel the event, they actually denied that they had done any of these violations. And they also suggested this public and private relationship with the NDOH, which it actually doesn't formally exist. So really looking at that political system. Then the second or the third level was the sectoral public policy. So looking at how the Department of Health, of course, they are the custodians of the R991, but there's often a lack of capacity to be able to monitor and enforce this, and we see this. And that also on top of it, the way that it's sanctioned or the way that companies will be penalized for this is criminal offenses. So it's where they know that the Department of Health will not be able to actually do that as effectively as maybe it says on paper. So it's just the loopholes that are used. And then 4 and 5, and this is also very important, is just how they change their environment. So looking at information environments, they're making it seem that their products are better than the recommendations that we as health professionals give of healthy, nutritious, complementary foods, or of course breastfeeding, and this marketing can distort these type of images and these ideas. And then of course, finally, level 6, that it actually can affect whether a mom will be breastfeeding their baby or not, and what types of foods they are actually going to be giving their babies that could lead to things like stunting or SAM or other health conditions. Next slide. So I know that I went through a bit of a journey before we've even gone to the Nourished Truth, but I think what was really important, because this was happening right as Nourished Truth was beginning in South Africa, and the reflections that have come from this Nourished Truth campaign have been that firstly, campaign framing and messaging are really important. So for example, with that one, the fact that it wasn't seen as just a violation of the regulation, was seen as, I'm a caregiver, Nestle is now trying to sell me ultra-processed foods that are actually bad for my baby. That really did get traction. So campaign messaging was important. Then collaboration and partnerships, of course, are so important. And we'll see the whole process in phase 1, especially of just getting everyone in the room, that it was so necessary to start a project like Nourished Truth. And then also just strategic planning and monitoring, and all of that is vital. And again, 3-day campaign. The Nourished Truth campaign is now, it can be a 1.5-year campaign that is implemented. And we need to have both proactive campaigns happening, but also just very reactive ones as well. And that combination is quite important. Okay, so let's get to Nourished Truth now. And this was really, like I said, a very collaborative process. So I'm going to hand over to Dr. Witten to take you through phase 1.
So I'm going to take you through the phases of the Nourished Truth campaign as the handbook. So when you open up the handbook, this is what you'll have. I'm going to talk about establishing the project, what we did for the transparency phase, and then the analysis and definition, and developing the strategy. So this part is the academic part. This is the part that was being housed by an academic institution. And I'm going to try and explain it in simple terms. So especially the students who are thinking about PhDs, thinking about your masters, if your countries pick up this as a proposal, this is the phases you'd be working through. Next slide. So let's talk about the establishment. So Angelica gave you a very nice landscape of what's happening or what happened in South Africa. We had 10 years of free formula. So formula is entrenched in our culture. Mixed feeding is the norm in South Africa. And malnutrition, we are number 1 in terms of childhood obesity and childhood stunting, given a middle-income country context. And so there's a number of organizations that have been working in child health, child nutrition, child development, and then we also had colleagues that were working in this ultra-processed foods and engagement of the industry. We call it industry interference and influence. So when it came to the university housed the project. but the team that was working around it, I want you to look at that. We had Wits University, we had the South African Medical Research Council, and the South African Medical Research Council was also the lead for the WHO multi-country study. So South Africa was one of those countries. There were 6 countries. We were one of those countries in that 55 billion report that WHO gave. And then we had another organization like HEALA, also an organization that is civil society driven, called Grow Great. And we invited our professional organization, the South African Dietetic Association. We also had the SAPA, which is the South African Pediatric Association. We invited them as well, but they chose not to engage. And part of this is about value clarification. Many of our health professionals are engaged with industry activities, and we need to acknowledge that. This is a new phase of trying to push back on industry influence and interference, both in academia, but also in health professions work. So rules of engagement are important. When you want to play in the same sandpit, you must have rules of engagement. And how did this work? Through the project Nourished Truth, we also had an MOU, both between the funder and the hosting organization, which was the UWC, but also we had a code of conduct between all of us working in the space. The code of conduct was both that we would not engage with industry, that we would not be aligned to anything that was in violation of our regulations, and that we would hold true to the objectives of the organization. As Angelica showed, many things were happening in South Africa. Sometimes you're on the left side, sometimes you're on the right side, but through this project, we all had to hold true to holding off on industry engagement. And that was a big ask. Remember that industry is engaging also through conferences, CPD points, what do they call it? Continuous education opportunities. And when you ask a whole institution to stop doing that, it is a big ask. So when you start your project, you need to be clear about where your participants are coming from. Next slide, please. So in terms of the actual academic part of it, we wrote a proposal. Remember, you have the project. So Family Loss and Rosenquist had a project plan for the UWC, but for UWC to generate data, we still needed a research proposal. And that research proposal was tabled by the University of Western Cape Ethics. It was a mixed method, multi-sector study, which meant that we could go back if we wanted to look at different players or sectors that we needed to engage with. And the basic question was, what are the strategies that the infant formula industry employs to either influence those that are influencing mothers? We decided in this project not to talk to mothers, but to talk to those that mothers value, that mothers trust, and that mothers consult. And so those were the target audience. And those are the questions that we went to the field with. So the mixed methods was in the first part was a scoping review. We did a landscape analysis on infant and young child feeding in South Africa. And then we started to do primary data collection from 4 sectors: health professionals, wherever they were located, either in societies, associations, or in networks, and then health professionals that were in service, mostly private sector. So we went to our private sector hospitals, private sector clinics, private sector pharmacies, and we engaged over there. And the last part was with media. And those are the questions that we went into the field with. Our scientific review was submitted in July, and we started data collection the month thereafter. So this is the outline of the steps that you would follow methodologically. The first one was identify the sector, which I just explained was private sector with those different target audience. Once you have the sector identified, we had an analysis framework that we thought about because we already knew how the industry was engaging from our scoping review. So if you're going to go into the data analysis field, there was some data that we were expecting, and there was some data that was going to emerge that we would not have known about. And that analysis phase was on 2 levels. One on an academic level to generate the themes and how do we think about the engagement. And then the second level, which was really important to have Family Laws and Rosenquist lead that process, was around operationalization. Because academia can be very staid. It can be almost unpractical to apply. It can come from a sector. This morning there was a presentation and one of the professors said, How is it that I'm sitting here and I don't understand the presentation? And that's because we have a different language, we have a different approach, and we have a different perspective. And so this collaboration has to be with academics because you want the rigor and the credibility, but also around the operationalization for where you want to take the work. So those were lessons we learned as academics. Next slide, please. So in the sector, we decided that we were going to target a number of the audience, which you will see listed out there. We also went across the province. Remember, Angelica said this was a national survey or a national project. It's for the whole of South Africa. So you can't collect your data in one county and then say it's for the whole of Kenya. Same way for South Africa, we have 9 provinces. We chose the top 4 provinces based on population of children, because they were the most affected, and then also where we would have the highest number of health professionals. 2 of the provinces are our central provinces in terms of urbanization, which is the Western Cape. You all know University of Cape Town, you know, the South African Medical Research Council, that's where they're based, and then Johannesburg as well, because urbanization is a big driver for why moms are engaging with formula industries. So we had thought that we were going to go into the field like excited researchers. We were going to get 130 to 150. Next slide, please. This is what happened. We as the academics did not do the data collection because this data would have to be shared openly and transparently, including with the industry. And so we outsourced the data collection. We outsourced it to a market survey company. But what we did do as academics was develop the tools, develop the analysis framework, and then wait for the data to come in. So all the data was collected across the provinces by trained market survey collectors, which means not biased to the views of academics, because we are also biased. We also use their techniques of market surveys. How they do it is not randomized by counting out people. They looked at a list of doctors in a set of hospitals and targeted doctors based on patient numbers, which also meant that part of this needed a lot of funding, because if you want to talk to Dr. Jane, you have to make an appointment and you have to pay that service. So you book an appointment and then you can engage with her for the next 30 minutes, which we don't usually do in research. So that was another thing that we learned. And so you can see we only then got to about 72 interviews that were completed across those sectors. But what the data did show, and when we did the analysis, they could not tell what was in the regulations because we had never actually translated the regulations for a lay person. And on your chair, you will find that HEALA has put together a discussion or an information pamphlet that decodes what are the regulations and how those regulations are applied. The second driver was around the activities and the inroads that the commercial formula milk companies use. All of us would like to go to a very nice conference. And if somebody else is paying for it, we would be happy about it. But it is a way of influencing you. And we know that this happens very early on in careers. So when your university is engaged with the formula companies and they can sponsor your lecturer, they can sponsor your exposure visits, they can sponsor your textbooks, you will have what we call loyalty. Brand loyalty is built like that. And for doctors, that brand loyalty works from the time that they are in the academic institution until they see their own patients. That is 40 years of loyalty. So that is another way that we really need to be focusing on. And then the second one was around information. You all have pamphlets. You're really happy to get something that you can take away with you. The formula companies were doing that very well, both digital information, printed information, conference information. Information is actually a value that academics have, that health professionals have. If we take that away, who's going to replace it? And that's why it's important for our governments to be engaged, because that providing of information should be coming from us that are promoting the breastfeeding. If we take it away, we need to replace it. And that is what came from our focus groups as well. All the health professionals said, if we need information, we can just WhatsApp them. We can call the rep. It comes to us. We don't have to go looking for it. So we need to think about it as if when we take it away, what will we replace it with? Next slide, I put in a I did put a summary slide so that it's not there, but I want to just summarize 4 things. 1, health professionals value the formula companies. We must not act as if that there is no relationship. It's not that they don't want to be engaged. 2, it's reciprocal. If you invite me to the conference, I will invite you back to my hospital. If you invite me to your CPD, I am more likely to support your product and your rep. And then thirdly, if we're going to take away what industry is providing, we need to have an alternative. Thank you.
Thank you, Dr. Witten. So when phase 2 happened, so now this is where UWC had completed their first part of the project. And I mean, as you can see, they had to do the groundwork, they had to do all the research, they had to do all of the collaboration, the real strategic thinking of how we can actually then have a campaign planned. So that's when HEALA took over. And as mentioned, HEALA is a civil society advocacy group. So there's an experience with campaign planning, communication, material development. Thank you. So we took over phase 2. And in phase 2, we had to do 2 things. The first was then take all of that research, think about those 4 different aspects that Dr. Witten had mentioned, the information, the R991, the activities of inroads, and then also medicalization of infant behaviors, and all of the ways that the industry then tries to convince healthcare workers that their formula is better than breastfeeding. And we now had to create messages for doctors, dietitians, and nurses. And we took a really thorough approach with this. So what we did, we hired a company to create messages for us based on all of this, obviously with a lot of workshops and input, and then piloted this with real healthcare workers working in both public and private around 4 of our different provinces also in South Africa. And we were then, I mean, we had to really look at these types of approaches very thoroughly with this piloting. And I think there was such a big value in this piloting approach, because when we're thinking about it as either academics or civil society or people that really have understood the issue, and we put it onto someone that was working with patients on the daily, with does have reps coming in, it's going to be a completely different approach that's needed. So, and we had to really think, how are nurses thinking, how are doctors thinking, how are dietitians thinking, what kind of work do they do, how do we actually get to them so that they want to make a change in the system as well. So it was a really thorough approach. And then, as Dr. Witten had mentioned, another aspect of the communication materials was this R991, or our regulation summary, just to help healthcare workers understand what is the things in that very long regulation that they need to know. When they see a rep, what is that rep allowed to do? When they see something in a hospital that's to do with formula, what can they do? And also, sorry, if we can go back, it does look like that if you're looking at your handouts there. But then also on top of it, of course, so we have our communication material, our advocacy material, but now how do we get to those healthcare workers? How do we actually try to start changing the system and the health system with all of the stakeholders that are involved? So this is where the campaign dissemination strategy development happened. And we did both advocacy and engagement plans. So the advocacy was really looking at how we're going to mobilize healthcare workers around this, the healthcare workers being the nurses, doctors, and dietitians. But then, of course, it's not just talking to healthcare workers, it's trying to look at the big engagements of our health professional councils are involved in this. Our associations are taking possibly funding from this. Our universities still haven't been sensitized to this issue when they're training healthcare workers. Our National Department of Health, who holds the R991, what can we do to strengthen it? How can we educate more people about, or healthcare workers about, our R991? So really looking at all of this, thinking about those different 4 elements that Dr. Witten showed from the research, and now creating these concrete plans. So, I mean, as you can see with this big purple box of establishing the project, phase 1 of the project, phase 2, there was a lot of work that went into this and a lot of thought that needed to happen. And now we are here in South Africa as well, exactly where the operational handbook has ended. We are also there in South Africa. We want to start implementing our plans. But we can go to the next slide, sorry. And this is where we're going to now see, where are these opportunities that arise? So we've got an 18-month plan in our hands. We know how we can talk to the different stakeholders that are so important and what we think would work based on all of these collaborations and the research. But one thing is that, I mean, for example, we've got our National Department of Health that has a infant and young child feeding or breastfeeding technical working group. So utilizing these relationships that we have to be able to reach healthcare workers, for example, mobilizing them through our big national level training platform, the Knowledge Hub, of this is an opportunity that we can use, that we can try and train more healthcare workers about the R991, all these types of issues. And then, of course, we also, again, here to talk about this operational handbook and how we can also go regionally where there are similar issues in Kenya, in Malawi, in Namibia, and all of these different countries that we can actually come together and try and combat this industry that's working so well with all these different countries. So we go to the next slide. So I do just want to focus again that we haven't implemented. We have now created this operational handbook to explain how a process like this could even be started in a country that has never maybe even considered it or is wondering how they could. And this is now, the purpose is to take these ideas and put it into some kind of actionable steps, and with a lot of help. So I mean, it has a lot of sort of stepwise approaches that were taken, but also just very practical tools that can be adapted. And this is not to say, I mean, it's amazing if this can happen on a national level, but it's NGOs could be starting this process, academia could be starting this process and seeing how it can work in different contexts. Next slide. So with this toolkit, there is an operational handbook that you're seeing on the slide there. And then in the toolkit, there's 3 different aspects. The first is this handbook. So that is where there's a lot of details written out of the stepwise approach that we took, that we've now gone through, how the project was established, what needs to happen in the foundational stages, the phase 1 of the project, moving all the way up until thinking about implementation with the campaign plan. We've also then, part of this handbook, within it, you can click buttons to get you to the process flowchart. So just looking at it at a bigger picture of a complementary type of flow to see through the handbook that you can get through it quite easily. And then I think a really, really helpful, hopefully a really helpful aspect of it is that we've included plenty of templates and examples. So I mean, an example would be something like this R991 lay summary. I remember when it came to HEALA and thinking, okay, this R991 is a big document. We now have to refine it to healthcare workers. What is the end product actually going to look like? Like, what are we going to hand over to people? And how are we going to distribute this? And so it's just an example that is in this handbook for you to just see, okay, this is where we can work towards. It will, of course, look different in your setting based on the context. Sorry, one last thing. And then the templates as well. All the way from phase 1 to phase 2, there's plenty of templates that are adaptable. It's different Word and Microsoft, PowerPoint and like Excel spreadsheets from all the way to from protocols of the research to the very complex budget and costing templates that you might need that you can adapt. So it's really, really trying to make sure that it's just as easy to start this so that time isn't wasted now doing the background work that doesn't need to happen, and that these are really trying to be as adaptable as possible. Next slide. So, I mean, if you would like to access this handbook, and we'll be having lots of discussions about it now still, you can go to www.nourishedtruth.org. And yeah, then I really do encourage you to just go look at it. It's looking, I think, again, reflecting on this project and how it all happened in South Africa. Breastfeeding is such a huge topic, and there's so many different elements that need to come together to really actually support and protect and promote breastfeeding. So if there is a way to try and combat this industry pressure that is put on the health system and actually protect children from the harms of formula and the harms of the industry, it is hopefully going to be a very helpful tool to everyone. Thank you.
I think before we go to the next presentation, I hope you have picked a number of things. The importance of working in partnership. Civil society organizations are very important in helping us promote health messages, because us as academicians, as researchers, we actually don't even have the tools, we don't have the skills. And that is not our space. So we normally write our science and our knowledge, and we stay in our corners thinking everybody knows. So the importance of working with the civil society of organization. The changing population dynamics is also going to give an opportunity for the industry to flourish. So we need to be very careful, and we really need, as frontline healthcare workers, to stand on this truth. The statistics she talked about in South Africa, formula having been free for over 10 years, now they have highest obesity. I think we need, and we know that obesity is a risk factor to NCD. So there is a lot that we have to do in protecting breastfeeding. The other thing I also want to appreciate is there is also no need of reinventing the wheel. The reason why we come to these conferences is to learn from each other. So I hope that we are going to take also the lessons. So as we go to the next phase, I want to invite Veronica Kirogo, who is the Director of Nutrition and Dietetic Services, the State Department. She sits at the headquarters of the Ministry of Health, to give her presentation before we go to the plenary.
Yes, it's good. We have had the first session on the Nourished Truth. But sitting where I sit as an implementer, a policy developer, it's important. We see how we move policy to practice, a case for Kenya, so that we can be able to see how do we then strengthen the protection on breastfeeding. Next slide. So as we all know, that we all start from breastfeeding. Is there anybody who has never breastfed to this? I mean, unless there's a medical problem. So that's where we start. And breastfeeding is one of the cost-effective primary healthcare intervention. And that's why we promote it. Naturally, it looks like a natural thing, but for us, that's the gold standard for infant nutrition. It is important for child survival. It reduces illnesses, and also is a key intervention in reduction of mortality amongst neonatal, infant, and young child mortality. And that's why it's really, we say, a very strategic intervention. But apart from that, we know that it is also important for maternal health. Research has shown that mothers who breastfed, they are able to reduce the risk of some cancers. They are also able to bond with the child, which is very important for growth. And that's why in terms of protection, then we have to protect the first presenter. They have talked about a lot of aggressive promotion of infant formula, which actually affect the choice of mothers to breastfeed. And that's why we are talking about protection. Next slide. Okay. This is the Kenya story. You can see from the graph, it shows our exclusive breastfeeding rates. That is the breastfeeding for the first 6 months. Starting from 1993, you can see we were at 23%. Only 23% were being exclusively breastfed. And it went on dropping. And of course, one of the issues that was bringing the dropping, of course, it could be the knowledge, but also the aggressive promotion of the infant formula. I remember, like, when I was growing, I mean, the time I was growing up, it was cool. I mean, mothers who fed their infant on infant formula were seen to be very progressive. And that's the picture that the infant formula painted. And so we have been, as a ministry, we have put in intervention, and you can see from 2003, where we were at 13%, we were able to go to 32% in 2008, and we actually doubled in terms of the rate to 61% in 2014. but we have stagnated there. Our Kenya Demographic Health Survey of 2022 actually shows we have dropped by 1 percentage point. And the nutrition professional and my team, we are trying to dig deeper to see what has caused that stagnation so that we can be able to accelerate the interventions that we are doing to be able to really promote the exclusive breastfeeding. But we can say one of the things that we can attribute this improvement, one of it is the policy environment. Yeah, we have the maternal, infant, and young child nutrition policy that the key driver in terms of the nutrition at that young age is breastfeeding. We also developed the Breast Milk Substitute Act in 2012, which is a domestication of the International Code for Marketing of breast milk substitute. And its aim, its purpose of that act is actually to promote breastfeeding, then regulate the marketing of breast milk substitute and also other designated products, including complementary food, the feeding bottle, yeah. So that's what we have put in that act, and we have also gone ahead and developed in 2021. We did develop the Breast Milk Substitute Act regulations, which actually prescribe the implementation of some of the clauses in the act, particularly the labeling. For those who are keen, in 2022 when it came to force, there was a change of labeling in the infant formula in the Kenyan market. And one of the key ones that we really fought with the industry as we were developing these regulations is having a warning label that breastfeeding, breast milk is the best. Yeah, and that when you go to the market, you will see it. It is in red. And also, we also have now the other provision that we have put in that label. Next slide. So our journey in terms of protection, we all know that our new Constitution 2010 provide rights to basic nutrition for all children. What is the basic nutrition for the young children, including infants? Breast milk. So our constitution is very strong in creating those rights, and it is our responsibility to make sure that any child benefit from those rights. Then the other one is also our Employment Act 2007. It's previously before that, the maternity leave actually was really a struggle because mothers were forced to accumulate leave days so that you can at least be able to stay with your infant. But the 2007 Employment Act provide 90 days paid maternity leave. That's the protection we are talking about. We are also trying to push if it can be in line with the recommendation of infant feeding, which is 6 months. The other one is our Health Act 2017, noting that our mothers after 90 days go back to work, but we are still emphasizing that they have to exclusively breastfeed this child. Then the work environment was not conducive. And so from the legal perspective, what we did is to have a provision in the Health Act that requires every employer to establish a lactation station at the workplace and also provide nursing employees with a flexi breaks, either to breastfeed or to express. It is still an enforcement, and so far currently over 300 organizations have lactation station. There's still a scratch on the ground, but we are still promoting on that. Then the other architecture is the legislative, I've mentioned the legislative safeguard, that is the BMS Act and the BMS regulation. Then the strategic system actors, including our Kenya health policy, It recognizes that suboptimal breastfeeding is one of the contributors of the child morbidity and mortality. And therefore, based on that policy direction, that's why we have been able to develop key intervention for promoting, supporting, and protecting breastfeeding. Then we also have the Kenya Community Health Policy, because the mothers are in the community. And therefore, we use the community health strategy so that the mothers are reached by our community health promoters. Currently, we are having over 107,000 community health promoters who do preventive and promotive health messaging at the household, including nutrition and breastfeeding. Then we have also our Kenya Nutrition Action Plan. That is our blueprint in terms of the actions for nutrition in this country. And one of the key resort areas is maternal, infant, and young child nutrition, where breastfeeding has been included. Next slide, please. Now, having legislation is one thing. Implementation is where things get challenging. So what have we done? After we developed the Act provides for establishment of a National Committee on Infant and Young Child Feeding. And this committee, one of the critical functions is to advise the Cabinet Secretary for Health on matters on infant and young child feeding. So the committee is active, and within it we also have 3 subcommittees, one on compliance, where we have various stakeholders who help in terms of the compliance matters. Then we have a technical committee, and the other one is finance and administration. So these are the structure that, when it comes to protection of breastfeeding, that support the government in terms of strengthening the compliance and also advising in terms of the technical issue. Next slide. So have this result yielded any impact? From where we sit, yes. Because globally, WHO monitor in terms of the accountability and compliance on the code, and I said our act is aligned to that code. So you can see in that chart, in that table, we have several areas that WHO, in terms of monitoring, they look at how countries are performing. In 2020, we had only managed to score about 69% in terms of alignment to the code. So we were actually moderately aligned. But after we developed the regulations, at least our score improved. You can see to 82%, which it's not bad. I think it was a great improvement, but then where the challenge is actually strengthening now the enforcement so that we can be able to score some more. Next slide. So where we sit, we also have identified quite a number of stress points when it comes to protecting breastfeeding. We are all aware in terms of like Kenya, the digital environment, the digital media, the mobile phone penetration. So when it comes now to marketing, it has become very easy because the advert is just a touch of your mobile phone, and we are in groups. So any infant manufacturer at times exploits those mothers' groups to promote the infant formula. So that's one of the greatest commercial influence that we are getting. We are happy that WHO are able to give the guidance on regulating digital marketing. So when we review our act, we are going actually to see how we can regulate the digital marketing. Another key one is the use of influencers. Yeah, so at times, you are occasionally I visit the Facebook. I can see Josephine is laughing, and what do you get? An influencer really promoting maybe breast, the breast milk substitute, and it has reached, she has over millions of followers. So what does that mean? It might, the gain that we have got can be just rubbished by digital marketing. And that's why we are saying it's a key stress, and we are looking at it in terms of how we are able to regulate. Then the other one is health system pressures. Chantel and Angelica actually mentioned about it, how the infant formula distributor manufacturer are able to get to health workers, so, fund some congress and give some IC material. And of course, what is that doing? It's making you appreciate that brand. And so you are likely, as a health worker, to actually recommend to mothers to use the infant formula. So the health system, we know there's a weakness, and what we are doing is really educating. We have found that sometimes it's very hard for health workers to really read the regulations. So you take the regulation and the act to them, which is simplifying to the way they can understand and knowing what is their role in terms of ensuring compliance. The other one is on humanitarian grounds. Kenya, we have 23 counties which are ASAL. Right now, it's good the rains came, but we were struggling with drought response because of the failed rains that we had in the short rain. And so what does that happen when the mothers do not have food to eat? When their household are food insecure, it affects also the breast milk flow. And so that creates an opportunity of the aggressive infant formula marketer to say, oh, mother, you don't have milk, we have this solution. So that's one thing we also try to regulate. And we already have maternal, infant, and young child guidelines in terms of emergencies. And they are one of the key things we emphasize is the compliance to the Breast Milk Act. Next slide, please. So what can we say? What we are saying is that in terms of protection, breastfeeding protection, it has to be embedded in the primary health care. And I said we have done that in the community platform because our CHPs, our frontline messenger in terms of promotion of breast milk promotion. Then the other one is on several initiatives. We start from the health facility. We have the Baby Friendly Hospital initiative, so that mothers are educated or demonstrated on how to breastfeed, including latching, and how to sustain the milk flow. And once they are discharged from the facility to the community, we have the Baby Friendly Community Initiative, where we have a community establishing mother-to-mother support groups to support mothers to sustain the breastfeeding. This year, we have started also having now father-to-father support group, because we found fathers mostly are the head of the household, they are the resource holders, and they are the decision maker when it comes even to the feeding of their family. So we are having those groups for us to support the mothers to breastfeed. Then at the facility, we have the growth monitoring and counseling. We have the maternal nutrition, and also we have integrated breastfeeding and other nutrition intervention in the reproductive, maternal, child, adolescence, and health platform, so that it is not a parallel initiative. Nutrition is integrated, and it can reach now so many people. Other data, we are tracking accountability. Exclusive breastfeeding is one of our indicators in the Kenya Health Information System, and therefore we are able to track. We also do it, monitor 5 years in our Kenya Demographic and Health Survey, so we are able to see how we are progressing. Our cost-effective intervention has contributed to our progression in terms of improvement of nutrition indicators. We have been able to reduce child stunting from 26% in 2014 to 18% in 2022. And we are saying it is one of the contributors. The other one is also the other 5 mortality rates. We have been able to reduce from 115 in 2003 to 41 per 1,000 live births in 2022. So if we can be able to scale to universal breastfeeding, I'm sure this can contribute to much more reduction. Next slide, please. So what are we committing as a country? We know we have not yet reached there. 4 in 10 children are not being exclusively breastfed, and we need really to reach out so that we can improve and have all children receive this gold standard of nutrition. But first, because the digital commercial influence is real, we really want to strengthen our legal provision so that we can be able to also regulate the digital marketing. The other one is strengthening monitoring and enforcement, and also expanding some of the key initiatives, the Baby Friendly Hospital Initiative and the Community Initiative, so that we are able to take the breastfeeding gospel to every mother and every community for their support. We also want to strengthen our National Committee on Infant and Young Child Feeding so that they can be able to operate. One of the key challenges is resources, and we are trying to mobilize so that we make that committee very active, because it's a strategic committee. I said we want to increase the exclusive breastfeeding to 68% by 2027 and 70% by 2030. So those are our aspirations, and I can say from the legal perspective, from the policy perspective, we have protected breastfeeding. What we are doing is just to increase coverage, and we are sure we can be able to reach where we have targeted. Thank you.
Thank you, Veronica. If you look at the statistics from South Africa, she said formula became free, now obesity is high. So we are not able to have a healthy population. We are already struggling with healthy populations. While technology is quite important, but you can also see is a risk, because digital marketing is now a stressor. To understand this topic further, I would like to invite our panelists who are going to take the other part of the session so that we can discuss these questions. I want to start with Veronica. Please join us here so that you'll also have an opportunity to ask her questions. So bear with us so that we can learn and promote breastfeeding as we tackle what we learned today. I want also to invite Esther Mugusu. Esther is the Director of Nutrition, Wellness, and the School Feeding Program in Nairobi. So if you've been wondering who is leading HEALA County, if you are Kenyan, this is Esther here. You have a chance to meet her. I know we have people from different countries also learn what they're doing in Kenya. I also want to invite Millie Karina, who is a nurse midwife. Thank you, Millie. And I want to invite Dr. Jane Mate Rodriguez, consultant pediatrician and lactation specialist. I would like to start with, in Kenya we say daktari. You know, the first person normally people reach when you have a child is daktari. Daktari is doctor. So I want to ask Dr. Rodriguez, he's a consultant pediatrician, so that she can help us understand, as a pediatrician in a children's hospital, where do you see the influence of formula on the standard operating procedures or protocols? And you can give examples from your experience.
Thank you very much. Thank you for having me. This has been a very insightful talk, and I'm very pleased to be part of it. So like she's introduced me, I have been in clinical practice in pediatrics specifically for just over 10 years. I've been at MPSHA for the past 10 years where I still practice. We have Children's Hospital at MPSHA for, I think, the past 6 years now. I think going through my practice, the places that I can see, I have seen the most influence from commercial milk formula for me would be in the procurement and the supply chain. Where I work and in a lot of private hospitals, those who've experienced it, its formula is readily available in the pharmacy, in the newborn units, it's convenient. So that's one of the places that I've seen a huge influence. You just, you barely need even a prescription pad to access formula in a private hospital. You merely just need to ask, is this brand available? We have the newborn formula, we have the follow-on formula. It's readily available. So that's one of the places that I can say I've seen a huge influence. The second part is the infant formula marketing, taking advantage or exploiting the knowledge gaps in the clinical areas. And this is amongst young doctors, nurses, nutritionists, dietitians. And I almost fell prey to that. And I think somebody has even mentioned this is the importance of this kind of collaboration. Very early on in my practice, we did not have this integrated in our learning when I was in undergrad and during my master's. We did not have the training on how to support a breastfeeding mother. Yes, we were taught about the policies in WHO and exclusive breastfeeding for 6 months, but what does that mean in clinical practice and on the ground? So when I started my practice, I genuinely did not know how to support new moms. And the challenges that come up is that you have a breastfeeding mom, she's going to go back to work, if she's lucky, in 3 months, if not, even earlier. How do you support her? And then I like what Angelica and Chantal have repeatedly and said, the medicalization of normal newborn development. If we do not know these things as doctors, as nurses, what to expect, the development of a newborn, when we talk about reflux, when we talk about gas, when we talk about colic, if we are not the owners of this information, then the information is going to be outsourced to the formula companies. And so they have anti-reflux formula, they have comfort formula, they have anti-colic formula. And that's how they infiltrate us, and they will come and tell us, listen, we have a solution for your problems. And what does that do? It places breastfeeding as the problem. My baby's having colic because my milk is problematic. And so this is another place we've seen a huge influence. And I am grateful for the collaboration with Kenya Association for Breastfeeding. And I was privileged enough from where I work to get training or additional training from what I got from my medical studies. And I was able to do a lactation and nutrition program with Kenya Association of Breastfeeding and walk the journey with the mothers so that when they come to the clinics, when they have delivered before they go home, then we have a clear journey, including troubleshooting and telling them, listen, babies will have reflux. We need to check on the baby's weight. We need to check on the baby's diaper counts. So we need to normalize what has been, let me say, villainized by commercial infant formula companies. So if we bridge that knowledge gap with our young doctors and our nurses, then it doesn't give an opportunity for the formula companies. And then the other place that I've also seen the influence is we don't do any audits in, I don't know, public hospitals do it brilliantly. I think in comparison to the private hospitals, we don't do audits on our supplementation rates. What is our rate of exclusive breastfeeding at discharge, at 2 weeks when they come for their reviews, when they come for their vaccination clinics? We don't check on these things. So again, infant formula and supplementation goes under the radar. And for as long as we do not look for these things, they will go unaddressed. So that's another thing we need to do. Clinical audits, we have to have quality improvement committees within our hospitals to look into these kind of things and curb this influence.
Thank you. Thank you very much, Dr. In Kenya, we say doctori. Thank you very much, Dr. for sharing that. That is quite a mouthful, and I think it's really taking me back to know that the pediatricians don't get all that. They have knowledge gaps in supporting breastfeeding. And that is where we all go. So you can imagine if they themselves have knowledge gaps, so what gaps then exist, what challenges and that our mothers are exposed to. Thank you very much. And even talking about no audits, I hope your job is still okay at where you are, because to acknowledge that we don't have audits in terms of supplementation. So forgive me, my panel is all ladies. I'm also one. And I think we said at some point, Veronica said we are including men. I also learned recently in Nairobi they are inviting men to bring their wives to the clinics. But that's something else that we'll talk after this session. After Daktari or after Daktari here, the next group that frontline health workers who spend a lot of time with our mothers are nurses. So I want to move to Millie because she spends more time with the mothers. So Millie, from your experience, what are the direct and indirect ways that formula companies influence feeding beyond the fancy packaging? From your experience, because you spend longer, and how do we counter emotional influences to mothers? Because you work with them, they come to you, you're the one in MCH, you're the one at the delivery room, you are always the one who is with them longer than the rest.
Thank you, Professor Lakati, and it's a lovely opportunity to be here with these lovely ladies on the panel. So I speak here as a nurse midwife and as a board certified lactation consultant. And what that means is I have been trained to have the highest accreditation when it comes to lactation management and lactation support. And the thing is, here in Kenya, I'm going to give the perspective of the bedside, as you have said, because we get to see these mothers both in private and public. And I actually want to say that I am the past chair of Kenya Association for Breastfeeding, which Dr. Mate was in. And I'm here with two of our executive committee members, Josie and Esther. It's lovely to be here with you. So in the front line, by the bedside, there's a midwife or the nurse who's with the mother. And there tends to be the problem of insufficient or perceived insufficient milk supply. So you give birth to a full-term infant and the milk has not yet come. The problem is not the milk has not yet come. The problem is maybe the healthcare worker is not sure of the amount of milk the mother should be producing. So they tell the mother, I think your baby is crying too much, and maybe it's because the baby is hungry. So they end up giving the fast feed as formula. When this is done, and because mothers tend to really appreciate the healthcare worker, they really believe what they do and what they say, this rubber stamps and says that formula is okay. So you have this mother leaving, even with a tin of formula, having discharged with it. It makes her feel that her body is not going to be able to be producing enough for her baby, and you leave a mother having to do mixed feeding. And then that has a domino effect, because when she starts mixed feeding, she's putting the baby less on her breast, and insufficient milk supply actually becomes a problem. The other thing is big baby. So you give birth to a big baby, and it is assumed that a big baby has big needs. So if mom is not overproducing, then this big baby needs to be fed. So we end up again giving formula. So those are just the indirect. And let me tell you, I don't want to bash the healthcare worker. This is the gaps that are there. a health worker who's unsure. All right, and formula will thrive on such gaps. Weak policies on even the best hospitals with have breastfeeding hospital initiatives in place, but the systems are weak, the policies are weak, then the formula will be there. And as Dr. Mate says, it is available in the pharmacy. All you have is request for it to be given to the mother. The other scenario I want to paint is the cesarean section scenario. The mother has a cesarean section and she's away from her baby for maybe 2 hours, and it is assumed that this baby needs to be fed. So the first feed again that the baby will be given is formula. Now we know a mom produces about 5, at most 10 ml per feed in the first day. The baby is given 30 ml. So what happens? The mom is playing catch up with her baby. Her body has not yet caught up to the 30 ml. She's just at probably 7. And then she is seen as having insufficient supply. So the formula game continues. And then here comes the night shift. We are few, there are babies who are crying. So what do we want? The babies to be quiet. And for the moms, oh, the moms are tired. So they need to sleep. So the nurse suggests, let me give your baby some formula. Yes, we have the best intention to ensure that the babies are calm and quiet, but these best intentions are now unintentionally set up the mom for failure. So we end up having the mother going and taking up formula, and even upon discharge, she's discharged with a tin of formula. We want to promote and ensure that these health systems, these health policies are strong enough to protect the mother and the baby. And it starts with where the healthcare worker is alone in the room with the mom and her baby. What is she informing her? How is she training her and teaching her in terms of breastfeeding? Because it only starts with, does she know how to latch? Because those are the things a lactation expert will look at. So we also need to ensure that the lactation manager or a lactation nurse, a lactation consultant is part of the healthcare team. We're not only working with pediatricians, obstetricians, dietitians. We need a lactation nurse involved to ensure that this mother, by the time she's being discharged, then she is successful and is going to continue on exclusively breastfeeding her infant up to 6 months and beyond.
She said knowledge gap is the greatest risk. A health worker who is not sure is really a threat to breastfeeding. Workload is real. These are realities. Thank you very much for sharing your experience. We want to move to the county level. Nairobi County has a population of 5 million. So we want to ask Esther here. She leads a school nutrition and feeding program. Very passionate about early childhood. Esther, how does the formula industry influence school administrators and educators?
Okay, thank you, Professor Lakati. So as you've heard, my name is Esther Mogusu. I direct nutrition, wellness, and school feeding activities in Nairobi City County. And so that means that within the school environment, we actually practice school nutrition, which entails nutrition interventions like micronutrient supplementation. We also do deworming. We do nutrition assessment, and we also do the actual school meals. So while looking at that environment, I liked the remark that Prof. Lakati made earlier, that we need to look at every opportunity. So here we are presented with an opportunity to offer a meal to a child in school. And of recent, it has become very popular. And we are actually spreading out to the counties. So the national government feeds the counties that are called the arid and semi-arid counties, which are 23 in number. But then there is this now, we can say there's a phase where every county wants to feed its children. And this has come about because of the devolution since 2013. So where counties were given the mandate of early childhood development. And one of the things that came with it was a free meals and nutrition program where counties then were to feed their children. So in Nairobi, since 2018, we fed our early childhood development learners, but then from 2023, we're actually feeding entire schools. That is right from ECDE to primary and all the way to junior school. So looking at the question at hand, so what are the likely violations? You know, this is a very unlikely and unconventional space. What are these likely violations that commercial formula manufacturers would actually interact with administrators and the educators? I've talked about ECD. So we have child nutrition programs, and someone would be very generous to say that we are coming to give education, especially to our early childhood development education teachers, so that we can actually have better care of these children. We have fortification programs, as I said, and we have some of them by proxy being supported by these manufacturers down the line. We also have dairy programs, you know, school milk programs, where we have value chain improvement, and we may find that down the lane, we have a commercial feed manufacturer who is actually sponsoring that program. So for administrators, what would be some of the opportunities? Receive sponsorships. Who do I want to study? Okay, go for this nice workshop. I remember Dr. Chantal talked about someone going for, you know, like this, stay in a nice hotel, attend a nice workshop, and get well taken care of, get some brown envelope, as we call it in this country. So that is very lucrative. Sometimes they would come in form of CSR, you know, corporate social responsibility. So we want to clean your school, we want to repaint your school, we want to do a bit of infrastructure improvement. So that's an area that we need to be very careful about. Donations. What are they donating? We are donating multivitamins. That is it's a nutrition program, okay? We are donating fortificants so that you can add them to your school meals so that you can improve the nutrition of your children. We are donating probably a packet of milk in a week so that you can have at least an animal source protein in the school meal for your children. So this is a likely area that we could have such violation. And they come in with a lot of branding, a lot of visibility. They'll bring the diaries, they'll bring the calendars, they will bring pens, they will give a lot of materials to the children. And when the children are able to relate a logo and associate it with another logo that is at home, probably on a tin of chocolate or on another tin of coffee, so then we develop what we call brand loyalty. On the other end, we have our educators. Educators are those who interact day to day with the children. Some of them are policymakers. So they also fall for the sponsorships and the trainings. These are the people who convene lots of meetings. Who doesn't want their meeting to be supported? Okay? We need meetings to be supported in nice hotels and nice places and get allowances. So those are areas where we can have such violations. Messaging. We heard from the toolkit that, you know, advocacy messaging is very important. And so we get some messaging that sometimes really conforms with, you know, promotion of infant formula use. So we need to be very careful sometimes with the kind of messages that we use. So not every poster, not every nice message is really supposed to promote what it purports to be promoting. So again, issues around branding, food containers. Who doesn't want a nice container, a nice plate, okay, for their school meal? So our children will be given nicely branded containers, but then it is actually promotion. We'd have school competitions, sports events, and then they'll be given gifts. And even, you know, like t-shirts and bags, and our cooks can adorn the aprons, okay? Aprons that are nicely branded, chef cups. So this is all about branding. A lot of IC materials. So we want to do murals on your walls. We want to promote nutrition. We want your children to actually have, you know, very good messaging on the walls. And yet, At the bottom of it, normally at some corner, there will be some brand visibility. So how do we counter this? So I like from the toolkit that we can actually do scoping. So what is the gap? What are the issues that we have? Okay, so let us scope, let us analyze that information, let's generate reports. And I like the fact that she has brought out the fact that we do not do audits. When we get someone to sponsor, you know, like we say, our school meal program has received so many dollars in terms of donation. We don't do a background check to just see who made this donation. So the person making the donation could be the face, but then when you go to the deeper background, then you realize that there's someone who is responsible for that donation. Declaration of conflict of interest all the time. If anybody has undergone sponsorship from these manufacturers, then they need to declare conflict of interest, so that if there's any engagement that is going on, then we'd know that if there's any bias that is going to be developed, then it has a background to it. Monitoring enforcement, which also goes hand in hand with dissemination of the policies and legislation and the guidelines. I know Madam Veronica has told us about how rich we are as a country in terms of policies, in terms of guidelines and all, you know, everything that needs to be done. But then how we do it and how we monitor. And it is clear that we have a lot of gaps in terms of knowledge, in terms of skills. And as we do this, because we are dealing with a lot of people, in Nairobi, I'm dealing with about 1 million learners. For public schools, I'm dealing with about 240 public schools, including early childhood development centers, and then thousands of teachers, okay? So when we include the private schools, there are lots and lots of schools. So we need to develop advocacy messages. So whom are we targeting? We need a message for everyone. Who is our primary audience? Who is our secondary audience? Who is our tertiary audience? And I like the guidance that has been given by the toolkit on how we develop our messaging, we test our messages before we now go out full-blown with our advocacy strategy. Something else that we'll need to do is to use the professional bodies, okay, to pass on these advocacy messages. We know that all of us, from our professional backgrounds, the rubber meets the road when my regulator will tell me that this is the gold standard and you must adhere to this, okay? So when I have checks and balances as a professional, then this is the person to target. So tell this person that your professionals must do 1, 2, 3. And if I go against what that code says, then I will be put to task. And also with a target audience. We are targeting school environment. Who are the stakeholders in a school environment? We have the parents, we have the learners, okay? You know, parents are an easy target because they are available. And once they hear that their children are going to be supported and there are sponsorships that are coming on, their parents' meetings that are being supported, probably some team building activities, they're going to be very excited. So we need to identify who our real audiences are. We have our teachers, again, who may be targeted. We also have our vulnerable learners, the teen mothers, okay? And when I talked about infrastructural development, we may have these companies come along to say we want to develop a lactation room so that we can support the teachers and the learners within this institution. So these are things that we need to be very careful about. And so there is no area where infiltration is not going to happen. So this is a very unconventional space. And I appeal to all of us, let's be on the lookout. It is good to allow ourselves, let us get online. We have been told about the policies and the acts and the regulations that are regulating breast milk substitutes in this country. Let us align ourselves, let's get the knowledge and the skills so that we can always be the eye of monitoring and also just speaking out the violations. Thank you very much.
Thank you very much. Thank you very much, Esther. I know time is not on our side. I want to move to headquarters, Ministry of Health. We have just, I think you've listed so many regulations. So, and as Esther put it, we actually not deficient of regulations. So looking at this toolkit from where you sit, how can the toolkit help the government in protecting or operationalizing the policies to better facilitate program implementation? Because I think for us, we don't have a shortage of policies, it's the implementation. What opportunity do you see with this toolkit to help us in implementation?
Indeed, the gaps in terms of compliance are there. Picking from what Jane was sharing about the gap in the health worker. But I think one of the things that, I can emphasize on is, that knowledge gap among the health worker is brought because of ignorance, because the laws are there. So health workers are not proactive to actually understand the legal environment. And I think that is the challenge that we are trying to address. So when I looked at the toolkit, I think one of the things as you are taking us through the stages, particularly the mapping, because it will help in terms of mapping who do we need to reach and with what, because there are different levels. So I think that is one thing I'm seeing, like where we can be able to utilize that toolkit, and also sometimes even the pathways for influencing. I mentioned about how the social media influencers are doing, but there are also other influencers. Those pathways that really propagate the promotion of infant formula and discourage maybe breastfeeding. I think it's a tool that can help at least understand, so that one can be able to really tailor the advocacy materials. I think a key thing also is conflict of interest, because I find sometimes health workers are actually not conscious of the conflict of interest. I can give one 3 years ago. In our biggest national referral, one of the infant manufacturer sponsored the rehabilitation or installation of a lactation station in our referral hospital. So what does that tell you? Of course, the infant manufacturer knew about the existing of the law, but our health workers were ignorant. Yeah. So even understanding, last year, one of the pediatrician, called me because they wanted to capacity build a county referral hospital. Of course, resources are challenging. But here come an infant formula manufacturer is saying, we'll support your training, daktari. Yeah? What do you need? But of course, she had to call me to find out. And of course, I told her, read the law, read the regulation. Is that ethical interaction? If not, then it's a no-go zone. So, health workers, I'm happy you are also here. And, at times in our meeting, we actually have to declare conflict of interest, including in the National Committee on Infant and Young Child. If there's an agenda you are dispensing, before the meeting, we declare. So that if you are conflicted, we know how to proceed. I think the other one is on the structured advocacy messaging. Yeah, sometimes as technical, we are so, our journals are so technical that we don't even communicate. And that's where now the communication, the advocacy team come. Yeah, because this technical messaging, I want to say so in an advocacy language, how does it? Yeah. So I think, having those structured advocacy messaging for the different levels of our target group is something that we can be able to borrow. And also, finally, you cannot implement anything without resources. So the costing aspect, and not just short term. If it is for the, you can see our target for breastfeeding at 2027 is 68%. So up to that period, what is the cost implication in terms of maybe advocacy messaging, in terms of protection, So I think that is something that maybe I have picked that the tool can support. Thank you.
Thank you very much. We are short of time, but I just want to allow Daktari here less than a minute because they are really normally in front. They're the first people just to tell us, where do you see the toolkit as for hospital administrators? And
the areas that have been covered by the toolkit, where we can see it working for us is, number one, we need to look at our clinical pathways as clinicians and just have like regulations where there needs to be some form of assessment before we suggest formula as a supplementation option. So if you put these checks and balances where you say there needs to be a clinical indication for supplementation of formula, this needs to be documented. There needs to be a lactation assessment that has been done, and then we are using formula as a prescribed intervention and not so much as your first option or natural option after breastfeeding. So I think that's one of the places that we can really implement a tool like this when it comes to the front-facing clinicians.
thank you. I just want to give her 1 minute to.
I think we also need to consider healthcare workers training to be sure that they know how to counsel a mother, how to protect breastfeeding from the moment a baby is born. We keep pushing about the first hour of birth, what needs to be done, but does the healthcare have that capacity? And at the same time, ensure that as part of the healthcare team, facilities need to consider now having lactation professionals part of the healthcare team.
Thank you. So, colleagues, this has been quite engaging. We'll not have time for questions. Please meet all these ladies during lunch so that you can ask them the many questions. But maybe some people are looking at me. Okay, let me allow 2 questions. Oh my God. Okay, there are 2 burning questions there. You know, I'm the one who made the rules of the hours of this conference, and I'm the one breaking. So,
good afternoon. I'm Naomi, an innovator. So my question is, how do we make sure, like, there are children whose parents like pass on after birth, or maybe they are in hospital, maybe the mother cannot be able to breastfeed at the moment. So how do we go about it? And then I have a presentation at the presentation room, a poster presentation, whereby I'm presenting Mama Drop, which is a community-based breast donor initiative. So you can pass by. I take you through it. Yeah. Thank you. Thank you.
Thank you so much. It's been such an insightful session. My name is Gladys Olisaike. I'm a doctoral candidate, and I have a number of questions I'll just ask to meet you guys later. So I thank you so much, Esther. I am an adolescent health everything, and I was waiting so much for anyone to get to her, that 16-year-old pregnant lady, and Esther just touched on it. What I collected my data in December, and the adolescent mothers I interviewed had no idea how to, like, what to do with this little baby in front of me and in terms of breastfeeding, and I had to stop my session to guide her. And not being a lactation specialist, I also struggled. What are you doing for adolescent mothers? How are you including them in your approaches? And then there's been a lot of emphasis on the commercial determinants, which I appreciate, but my experience, I am Nigerian and my fieldwork was in Nigeria, and that I met adolescent mothers who were trained to, of course, or not trained, they had health talks on exclusive breastfeeding, and they went home, but at home, they interacted with these other older mothers who told them that their breast milk is bad because they put ants inside her breast milk, and the ant died, and they told her that means if your baby takes it, you'll die. Her auntie gave her one box of infant formula, which I appreciate how you put it, that whenever there's a weakness, the infant formula just fills the gap. And then when that one thing finished, she's an adolescent mother abandoned by her parents. She can't afford it. She went to giving her baby pap, watery pap, until the baby was really sick. What do you do in this instance?
Thank you. Thank you.
Thank you very much, Prof, for that opportunity, and thank you very much to the panelists for those wonderful presentations. I think when things are good, you need to appreciate. So I picked something on the indicators, the under 5 indicators. I think when I looked at how you've moved those under 5 indicators, I'm really impressed. As a public health practitioner, I think that's what we want to see. And you are doing a commendable job. So I'm very happy to see that, and I thought I should commend you for that.
Thank you. Let me allow, I think the question can be either answered by anybody here who, do you want to answer the question?
I think I'll start off with the first question about what happens when you have a premature death of a mother and the infant is left. So in Kenya, we are privileged to have a human milk donor facility at Pumwani for those who are not available. So this is one of the channels that we are trying to educate mothers about. And it happens where it's not even just death. The mother may be unwell, she may be in the ICU, you may have twin gestation and not able to sustain. So we do have human donor milk, which is regulated, and Pumwani is doing a very good program with that. And so we are looking into these alternative options. And also, like the lactation consultants who support a lot of mothers, most of them have a lot of excess milk. And we are also encouraging them to join the donor program so that we are able to help mothers now who either the children are not, the mothers are not available to breastfeed, or for whatever illnesses or conditions, they're not available, then they are able to donate this milk through the banks. So that's one of the ways we are considering before now pushing them onto formula.
Esther, do you want to answer the question?
Oh, yes. So thank you, Gladys, for your question. And I know adolescent mothers, it's a delicate space. And something that we've had with educators, I know there's a policy in this country that when a girl gets pregnant, she's supposed to stay at home until her baby, is big enough. Actually, they say she's supposed to stay at home for 1 year. That's something that we've actually been in conflict with educationists, but it's something that we are really trying to offer a solution that is domesticated. So what we do with the adolescent mothers, so number one, within the school environment, we will provide a space where the mothers can come with their children. They're really girls. Sometimes you even feel guilty calling them mothers, but they're mothers anyway, because they have children. So we provide space that is set up for caring for their babies. So they come in the morning, they will bring their babies there, and they're allowed to go to class. So we have some lay caregivers who have been trained and who take care of, the babies while they're there, not to feed them, but just to take care of them. And the girls are given flexi breastfeeding moments during breaks in case the baby needs to feed before a break. Then they will be called from their respective classes so that they can come and take care of the baby. We also have psychosocial support that is being given to them. They're counseled. This is a child who is taking care of another child. So probably facing a lot of rejection from the family. So they're given that kind of support. And for where we have partners who are supporting, then they will get, so they're given dignity packs, like just parts for themselves and a few personal effects to take away with them home and to just make them feel like they're still girls. And then where we have support, they'll get a food basket. There's some who come from really vulnerable backgrounds and they need that support so that they also support their families back home. Some have been thrown out and are even staying alone or with relatives who cannot be able to support them. So that is what we are actually doing for the girls in Nairobi. Yeah.
Thank you very much, Esther. We have had a very insightful session, and colleagues, as we come to a close, we have a toolkit.
Before we close, let me respond to Naomi. Thank you very much for the question, and particularly in terms of the human milk bank. Actually, the Pumwani one, it's a joint collaboration between the national government, the Nairobi County government, and also other, Path as quite an expert in terms of human milk bank. So it is a pilot that we did to inform in terms of policy how as a country we will progress. Right now, what Pumwani does is that the mothers who donate the milk, they are screened. They follow all the screening procedure, but they are mothers who are admitted in that hospital. Yeah, because you see the issue of safety of that donated milk is very critical. I know you brought in the issue of the community. We have not moved now to the community because what we have done now, we are expanding the initiative in Pumwani. Actually, we had started work with Bagathi Hospital, and also looked in Mama Luce and Kenyatta, so that we understand the issue of the community linkage, so that we can give really informed policy direction. So at the moment for Kenya, we don't have a policy for mothers in the community to donate because of the screening procedure. Yeah, because we don't want where you expose babies to risk from the donated milk. Maybe the other one, Chair, if you allow, in terms of Gladys, you asked about the grandmothers or the old mothers' influence. It's also here in Kenya. And one of the initiatives that we are really scaling up is what I said, the baby-friendly community initiative. Because that's where now you get in the grandmothers, the opinion shapers at the community, for them to understand why they need to protect and promote and support breastfeeding. So we are able now to deal with those, misconception about the breast milk and all that at that level, at the community level. And now we are using the strength of the over 100,000 community health promoters. What I can say like now currently, at the community level, we have what we call community health units. As of last year, we have over 1,000 community health units who are implementing the baby-friendly community initiative. So with that, if we're able to scale to all community health units, we will be able to change that, misconception, misinformation, and probably will be able to protect breastfeeding.
Thank you very much. So colleagues, you can see this topic is very difficult to finish because this is about life and this is about healthy living. So I want to thank these panelists. Please appreciate them. So as we close, we have a toolkit that is available. Please interact with this toolkit. We don't need to reinvent the wheel. It has gone through the rigors, the methodological approaches, as researchers like to see how was it developed. I think we have gone through that, so we can see that there is a toolkit that we can borrow, we can modify, we can learn from it, as they also work with it in South Africa. But we have also learned a lot from these colleagues that we are at risk of reducing breastfeeding if we don't protect it. Because we can see that from digital marketing, from knowledge gaps of healthcare workers who are our frontline, where else do you go it's the health worker. So if the health worker has a knowledge gap, that is a very big risk. So there is a big opportunity for us to deepen the training of health workers on breastfeeding, on how to support breastfeeding. There is a very big opportunity to strengthen to partner and actually work with administrators, because what we have seen from this discussion, the exploitation of the knowledge gaps is the key thing. So health workers, let us educate ourselves, learn more from these ladies and our partners so that we can promote breastfeeding. With that, I want to close this and say breastfeeding is one of the best intervention to promote child survival, towards universal health coverage, towards reducing NCDs, and all the many other things we cannot mention. Thank you very much. Have a good afternoon.